Hello, everybody. Hey. I see all my friends and lots of new people, which is awesome. My name is Adrienne Larkin. Every year I keep track of the new research on traumatic brain injury to see what's going on, always with this idea of explaining to me why it is that what you do makes you so successful when so many other great clinicians and researchers just can't seem to get anywhere. And I'm really happy that there's a lot more research coming out that's published about cranial work and osteopathy and concussion. These are mostly case studies, but that's the basis. That's the foundation of the pyramid where you prove that it works and then you do more sophisticated research studies. And the second question that I ask is, why does this happen? Why is it that 30% by some studies of people who have concussions never get better? There's got to be a reason for that. I am not a physician, as most of you know, but new people, I'm not a physician. I'm not a researcher. My professional career has been as a trial and appellate attorney. And people ask me, what's an appellate attorney? Like, someone sued, someone lost, and someone is still mad. And that's when an appellate attorney comes in. It's actually very good practice for doing this kind of paper research because you learn to spot facts that don't support hypotheses really quickly. And you really learn how to spot facts that just don't add up. And another iteration of my life, I have a master's degree in the philosophy of science from a Northwestern University with a specialization in the theory of scientific explanation. What is it that makes a theory a good theory? It has to make sense of an enormous amount of information, make it tell a coherent story, and it has to have predictive value. If your theory is good, it's going to say to you, if you look here, this is probably what you'll find. So when I'm trying to think of why it is that what you do makes you so successful, I have that kind of background in mind. And I have to give a shout out to Dr. Hope Toby. She published this about a month ago in your journal, a study of aged rats who were not doing very well.
Some of the people in this room?
Yes, exactly. Exactly. Kind of like losing their marbles. And they did cranial work. She sent me a picture. Where's my picture? They did a CV4 in a mouse, actually a rat. Just like that. And the rats were a lot smarter at the end of the treatment, which is awesome. So what I'm saying to you is, if you feel like sponsoring some excellent research, Dr. Toby's been working on this for 5 years, and they're having trouble getting funding, of course, as always. So, send her a few bucks, maybe. Okay, so the way I approach this is not as a researcher. I hope that I'm trying to avoid boring speeches. I approach it kind of like a closing argument. This is my own thing. So I start right at the beginning. At its worst, this is concussion. It's an insidious, long-term, whole-body disease process. It involves multiple organ systems, and it can persist for years. This is not just you get hit in the head, you wait for 2 months, your symptoms clear up, and you're done. In a lot of cases, there's a pathology that's underneath the surface that goes on for years. Okay. Brain recovery lags behind clinical recovery. This is what the research is telling us. More and more of this is coming out, and it doesn't change. If anything, it reinforces the same thing. These are the things that they're finding go on long after people no longer have symptoms. Lots of things. Long term. Okay, so that's what the pathology is under the surface. And now the countries who have national health care are mining their databases and trying to figure out what happens to people over 10 years, 15 years, 25 years after they have a concussion, because they can track people longitudinally. This came out about 2 months ago. We suspected it, but this is what they're finding. It increases your risk of heart attack, of stroke, of Parkinson's, early death from all causes. And it's higher if people have a prior psychiatric disorder. There's a reason for that, which I'll talk about at some point. Adolescents have a bad situation going on. They have an increased risk of multiple sclerosis, and this very famous study from Sweden tracked kids for 25 years after a single concussion. They are much more likely than their uninjured siblings, sometimes they're uninjured twins, to be admitted to a mental hospital, to have a worse work history, to have disability benefits, poor school attainment. Something is going on with the brain. Why is the brain so bad at managing its own healing? Because we're talking about concussions. We're not talking about severe brain injury. And this is the most famous and one of the most disturbing. It increases the risk of suicide. And the more they look at this, the more this is reinforced in the data. And it's not just 5 years, 10 years out. You know, there are these terrible case studies of kids, of adolescents, who get hit in the head from sports and 4 months later take their own lives. You know, what is going on in the brain that makes it? Okay, so post-concussion syndrome. You want a good theory? It has to explain this. You know, right now, it's a syndrome, which means it's a data dump. You look at everything that happens to somebody after concussion, you put it in a box and you say it's a syndrome. I mean, that's progress. At least you know kind of where to look. This is the model. And I know a lot of you guys have seen this, but I like this. I like this. This is what happens to your neurons. And as far as it goes, it's really right. You get hit in the head, boom, your axons stretch. Axons hate to be stretched quickly. And that will be something I come back to later. And then, you know, they have holes in them, then they leak, and potassium goes in, and potassium goes out, calcium goes in. The mitochondria are trying to help out. They take all that calcium and they sequester it. They think they're helping, but it gums up their works, which means that just when the neuron needs all the help it can get to fix itself, the engine that runs it starts to falter. Meanwhile, blood flow goes up and then it goes down. So just when you need the energy, you don't get it. They call it an energy crisis. Meanwhile, all of that metabolism is generating oxygen, right? That's what happens. Metabolism's byproduct is oxygen. Oxygen is a little tramp. It needs to hook up with something. You know, it looks around. Your antioxidants get all burned up. Where's the best place in your brain? It's in your membranes. They're full of little electrons they can hook up with. So it starts to literally rust your brain. And then inflammation is going on and then your cells die. Most of the literature looks at this process and picks it apart. Like, if we could only stop this, if we could only stop that. And I call it like the neurocentric approach. We love the neuron. It's a rock star. Everyone loves neurons. They're beautiful. They run your brain. So these are your neurons in your city, right? This is your brain. This is the way people think about it. And that's what happens after concussion. The neurons like kind of fail. And if this is your model, you look at that and you go, what that really needs is a new coat of paint. You got to fix that. You got to paint that thing, and you know, maybe pump up the foundation a little bit. And the garage fell on your car, so you need a new car. And then you'll be fine. I mean, you have to walk like this, but you'll be fine. But my idea is, did you notice you have no roads for your new car? You have no gas. If you drive a Prius, you have no electricity. You know, your neighbors, did you notice your neighbors are dying of cholera because the sewage is backed up? And by the way, the whole thing's on fire. If your model is of a neuron and you focus on that, you will never understand why the brain can't fix itself. So I'm going right to the way I look at it. You have to do 3 things. And this trio of approaches was something that was developed during cross-examination of Maud when she was writing her book, Healing Pain and Injury, and I said, give me the top 3 things that osteopaths do that are different. You got to come up with a list of 3. First one, balance the autonomic nervous system. Second, restore fluid flow. And third, put things back where they belong. It's the same thing you do in the body. It's not any different in the brain, in my opinion. This is just my opinion. Okay, so I'm going right to it. First thing you got to do, fix the autonomic nervous system, bring it back into balance. The autonomic nervous system is a champion, or as I like to call it, it is one system to rule them all. It's so obvious to me as a layperson. I mean, what is the one system that runs everything else? What is the one system that has its feelers and tentacles in every organ system in the body? Virtually every cell in the body has receptors that respond to the ministrations of the autonomic nervous system. It's the one that's in charge of bringing things back into balance in every organ system. So Maud told me I may not belabor this due to the fact that osteopaths are trained from birth to revere the autonomic nervous system, and you know how to treat it. So I am just going to take 2 minutes to belabor this. You should know 3 things. Number 1, assume that your concussion patients have an autonomic, they call it autonomic dysfunction, but really it's the sympathetic nervous system taking charge. I mean, danger invites rescue. That slide I had up there, that's a principle of the law, which works very well in the body. What is more dangerous to the body than an injury to the heart or an injury to the brain? And so danger invites rescue. The first rescuer is the sympathetic nervous system. And it just comes in, and you test anybody after a concussion, and they will have high sympathetic tone. I don't know that I would call it dysfunction. However, now they are looking at this, and they realize that autonomic dysfunction persists for years, or it can persist for years after the symptoms resolve. So underneath, all of those problems are festering. And the third thing you need to know, it's vastly underrated. You guys know that. But finally, they're doing research on the autonomics in concussion. They have most of this research is taken over from severe brain injury, because they know in severe brain injury, you have an explosion of sympathetic response, so severe it can kill the brain. So they're kind of borrowing from that, but they're actually looking now at the pathologies that are tied to the autonomic nervous system. And here's my chart. I'm almost at the end of my belaboring. I mean, look at the comparison of post-concussion and autonomic. Headache, check. Dizziness, check. Fatigue, check. Cognitive impairment, check. Anxiety, depression, check, check, check. Does that mean that autonomic dysfunction causes everything? No. I mean, this is a multifactorial injury. But, looking at that chart, you have to think that the autonomic nervous system has a lot to do with it, and the studies are starting to show that. Talking about, just for a second, that it gets no respect, they're starting to do taxonomies of concussion. Like look at it a little more carefully, which is good. You will not find autonomic dysfunction. It's just not on their radar. Not yet. Okay. End of rant. All right. So I'm going to tell you 2 things that you may or may not be familiar with when you're treating people to have in mind concerning the autonomic nervous system. Someone asked me before the talk to do something on PTSD. So this kind of is about PTSD. If I ask physicians, If I told you that the autonomics were dysfunctional in concussion, what do you think what is the first thing that comes to mind about what organ system? And everyone says the heart. Because the sympathetics and the parasympathetics have to cooperate in that little dance to respond to different demands on them. You stand up suddenly, the parasympathetics have to let go, the sympathetics have to come online, or you're going to faint, which is, of course, what happens a lot of times to people after concussion. Heart rate variability is the measure that they use. How much parasympathetic input, how much sympathetic input. It's a marker. It is a surrogate for how the parasympathetics are doing. Because there are lots of reasons that you have heart rate variability problems. But when you do, what it's telling you is the parasympathetics don't have enough oomph, and the sympathetics have too much. These are the things that have been hooked to heart rate variability problems, having nothing necessarily to do with concussion. There's a huge body of literature about this out there that was done long before they realized that this showed up in concussion. So these are all the kinds of things that can show up with heart rate variability, with autonomic dysfunction. So there are two groups of people that care about that a lot. First group that cares about it is athletes, because they want to get playing. And I can tell you, as a former basketball coach of many years, that's why it's so hard to get them off of the court. They really want to get back into the game. And so the athletes and their trainers noticed this kind of collection of symptoms. They stood up quickly and they got dizzy. They got back on the treadmill and they started feeling terrible. And they measured it and they realized that the way the sympathetics were managing the heart was just not working. It was a heart rate variability problem. It can be modulated. It has biofeedback characteristics, at least with athletes. So that, your return to play protocols, that's kind of based on the fact that heart rate variability is something that's responsive to feedback. And you can buy an app, if you don't believe me. You can buy an app that fixes your heart rate variability. Okay. And there are some studies, there are 3 studies actually, of OMT showing that it affects those parameters, that you can get more parasympathetic tone, and heart rate variability can stabilize. However, the last thing I'm going to say about this is now they're realizing that these problems last much longer than the symptoms. They took football players and measured their heart rate variability before the season, and they had a concussion, and they tracked them every day, all the way through return to play and beyond. And even after they were symptom-free, their heart rate variability was skewed, which is to say you have a deep autonomic problem that's persisting. And the question is, what else do you think is affecting? Your metabolism, your cerebral blood flow, all the other things that the autonomic nervous system runs? They know from old studies having nothing to do with concussion that these things are related to heart rate variability. So when you are balancing someone's autonomics, you are not just getting them back on the field, you are also maybe saving their life in the long term, because it's been connected with all of those syndromes that I showed you in the beginning, that they are throwing up their hands and going, we have no idea why this is happening. Well, maybe this is part of it. Okay. The second group that really cares about heart rate variability is the military, because there is also a pretty significant body of research that mostly is coming out of the military, having nothing to do with head injury, that says when they measure how your parasympathetics and sympathetics are running your heart, they find problems that are linked to PTSD. If you have lower heart rate variability, which means those two parameters are closer, that's not a good thing. If you start out with kind of impaired heart rate variability, you're much more likely to get PTSD when you come out. And biofeedback is starting to help, and if you undergo resilience training, you're much more likely to do better. So this led me to this question. Why is it that somebody, a kid, is fine on Saturday morning? They're a happy kid, they're a good kid, they go and they play football, they get hit, they have a bad concussion, and 4 months later they take their lives. What sense does that make? This is, their scans are clear. No, explain to me how what's considered a minor hit on your head changes your mood, changes your outlook on life. They become depressed and angry and irritable. So I started looking into what I call autonomic dysfunction 2.0. If you think of 1.0 as your, the vagus nerve, and we love the vagus nerve, and it's great. But then you start to look at what else is involved in autonomic responses. Okay, by the time the hypothalamus is sending instructions to the adrenals to get that that adrenaline into your system, it's already been talking to the olfactory area, to the frontal cortex, to the hippocampus, to the thalamus. It's been talking to the smart brain, to the fear centers, to the brainstem. It's been talking to all different parts of the brain. So if you are talking about autonomic dysfunction, you can't just focus on the vagus. It's this whole complex of things that feed into the fear response, that feed into the mood response. I call it the neurobiology of fear. So they call this the central autonomic network, and you will never get two diagrams that agree what's in it. And eventually, if you put them all together, it would basically be the entire brain. But what they're saying is, it's not just your brainstem, which works when you're asleep. It's not just the middle of your brain, which is kind of a bridge between the ancient and the modern. It's all of these things talking to each other that happen in an instant and tell your body to start producing those sympathetic hormones. So this, to me, is a premier example of how injury to structure affects function. In the situation where someone is just depressed, they know that there are certain structures that are impaired, but they don't know if the depression impaired the structures or the structures impaired, the impaired structures caused the depression. They don't know which way it goes. But in a concussion, when you're happy on Saturday and you're miserable on Monday, that's telling you that the structure was injured, because that's what's causing the change in function. There's no other explanation. I've had 24 concussions, including 7 times I've been knocked unconscious. And I can tell you, it's annoying, it's frustrating, it's scary, and it can be depressing. But there's a quality of depression. It's just depression over life circumstances, but these kids are taking their lives. This is a structural issue. So the question is, what are the structures? And to me, there are 3 of them. The first is what I call the smart brain. The smart brain up here is telling your sympathetic nervous system to calm down, that is not a real bear. That's a circus bear. It rides a bicycle when you're not looking. It begs for money. Calm down. If you sever the connection between the cortex and the hypothalamus, you get all kinds of rage responses. I call it the hypothalamic fight club. And a lot of things feed into it. It's not just the hypothalamus, it's this ancient part of the brain that its job is to say, you're in danger, run or fight or freeze. It has no thought to it. It has only a very primitive cognition. So they found that if you stimulate that, you get hiss and spit, you get amplified rage with that, you get predatory aggression if you stimulate that little hypothalamus. And I found a film from the 40s where they did this research. This is kind of mean, so.
A clearer experiment was performed with cats. In this classic example, the hypothalamus, the rhythm maker, was implanted with electrodes. Could it be responsible not just for rhythms, but also for rage? The switch is turned. Then the switch is turned off. So indeed, the hypothalamus does control certain types of aggression. Yet, when another region of the hypothalamus is stimulated, we see another kind of aggression: the quiet biting attack, the silent stalk after a rat, and the calculated kill. Turn off the switch, and the kill is forgotten.
That's so mean. It doesn't mean that all rage is controlled by the hypothalamus, of course. It's kind of an extreme example. What it's telling you is that parts of the fight club are in charge of, very, anger and rage and things like that when you sever the cortex from it, when you sever the smart brain, the parent in the room, from it. To me, the hypothalamus is kind of, all roads lead to the hypothalamus. It gets input from the cortex. It tells it to calm down. And if that's not there, then you have excessive sympathetic tone, let's just say. So to me, that means what connects all those pieces. You have the fight club, and then you have the smart brain telling the fight club to calm down. And then they have a telephone wire between them that they have to communicate through. And so there are three parts. And the telephone wire is a part of a white matter tract called the uncinate fasciculus, which is one of my new favorite parts of the brain. And it's that blue U-shaped thing there. And it's easy to remember because it's a U. So theory would predict that if this is correct and you have injury to that is affecting this, you would expect that when you have those kind of symptoms, there might be a problem with that wire. And this is what the research shows, that there's decreased integrity to that white matter tract. They've studied cops with PTSD, kids with behavioral problems, depression. It's one of the most commonly injured white tract matters in the brain because it runs right here and right here. This was a study that they did with kids. The first up there is a control. The second kid had a concussion without problems. And the third kid had behavioral symptoms. Is this everything? No, the brain is too complex. It will rewire itself eventually, or it might. I'm just pointing this out because this is something you should look at. You might want to look at if you have PTSD. Okay. So the last thing is the smart brain. Suppose the wire is okay. Is there any evidence at all that there's some problem with the smart brain in PTSD? It turns out that what I call the smart brain is the orbitofrontal cortex. That's where the uncinate connects the middle part of the brain to the smart brain. And this is what they find. That at least in some cases, the orbitofrontal cortex loses volume in cases of PTSD. And people who have antidepressants and the antidepressants work gain volume in the orbitofrontal cortex. It's also, this area is one of the most commonly injured. This is a top-down system. The smart brain puts the brakes on this primitive reaction to injury. And if any part of that is damaged, you're a much higher risk of PTSD. Okay. And those are the areas: orbitofrontal cortex, uncinate, all those places are commonly injured. Okay. So I'm just leaving that. And the last thing I'm going to tell you about the autonomic nervous system is that ANS dysfunction primes the inflammatory pump. How many people have patients who are fine and they're doing really well, and then they hit their head again? A small hit, or maybe they're even almost hit their head, and all of their symptoms come back. And it's just like, you have no idea what just happened. Well, let me give you a possible explanation. Danger invites rescue. Who rescues you when you hit your head? The immune system. The immune system comes in to clean up all the debris. And the brain has its own. They're called microglia. And there you see, they're so nice. They hook those two broken blood vessels together and fix them. We love microglia. They're very smart. There are millions and millions of them in your brain. Because they do lots of things. They prune your synapses. You know, if you got too much stuff and you're too smart, you got too many synapses, they'll prune your synapses. They're very handy. We really need our microglia. The thing is, they go bad. They just, you know, they're not that smart. I mean, their idea is the brain is injured. We're an immune cell. You know, if you have too much stress hormones in your brain, too many glucocorticoids, the microglia get the message, the brain's in danger, don't stand down. Stay alert, stay ready to fix it. And what happens is they stay in what's called a primed state. They stay hypervigilant. And so the next time you get a hit, they overreact and you have a much more amplified immune process. This is called the two-hit hypothesis. And it comes out of psychology. They've studied this for years and they're only beginning to take this over to traumatic brain injury. But we have the data from years and years that this, you know, this can be any stress. It can be any psychological stress. Anything that ups your glucocorticoids makes the microglia, you know, the brain doesn't know the difference between a physical injury and a psychological injury. It's all steroids to them. You know, if your glucocorticoids are high, the immune system reacts like you're being chased by a bear. So, what has the most glucocorticoid receptors in the brain? The hippocampus. And when I first was going to what I call Wikipedia Medical School, whenever I do these presentations and I have to look things up, it's like hippocampus, hypothalamus, who can keep these straight? But the hippocampus is really easy because what goes to hell when you get old? Your memory and your hip. So the hippocampus has to do with your memory, so it's really easy to remember. The hippocampus is your memory center. It has the largest stem cell niches in the brain reside in the hippocampus. And it has its own cohort of those microglia that are have specialized training in the hippocampus to birth and tutor and nurture those stem cells. If you don't control the autonomic reaction, you are putting a time bomb in the brain's ability to regenerate, because the microglia who are in a primed state cannot be good mentors to the stem cells in the hippocampus. What happens is they never live. They don't migrate, they die. And if you don't think that they kill the stem cells, this is the thing, if you don't think that glucocorticoids kill the stem cells, this came out last week. That stress turns your hair gray because it kills the stem cells that have the color. I was so upset when I saw that. I was like, you know, if I'm going to lose my marbles with all my concussions, I want to look good, at least. And now it's telling me I won't even look good, you know, my hair is going gray. So the mice went gray in 5 days. It's very sad. It's very unfair. Okay, so microglia getting a bad rep, now being associated with everything. They're being blamed for everything. Now they're being accused of being sexist. And I believe that given their bad behavior and this history of being bad, I think that microglia were on the Ukraine call. All right, so this is a real thing. You see that lesion up there in the right-hand corner? That's where you got hit. And the microglia that are activated send messages out to everywhere else in the brain. And all those little inflammatory processes that go on in your brain for various reasons, they start being amplified. So you got to control the autonomics. On the left side, reduce the stress response. All is not lost. If you reduce the stress response, it will calm them down and they can go back to homeostasis. But people that you have who still have this sympathetic profile in their brain where the sympathetics are just going nuts, they get hit a second time, it explodes because the microglia, for one thing, are so primed to act. Okay, so those are your takeaways for ANS dysfunction. And you are the masters of the autonomics. You've been working on them, for 100 years. And that's the best way to treat the autonomics, is you have somebody like someone in this room treat you. Okay, second thing, why is it that what you do is so successful? Restore the brain's fluid flow. I have under instructions not to belabor this either, because you guys are the masters of flow. Here's the modern iteration of that principle. All neurodegenerative diseases are associated with the accumulation of cellular waste products. That, by the way, is no longer correct. It's cool, but it's also, they consider that a little bit not accurate. Why do you need good fluid flow? All roads lead to inflammation. What happens to the brain? This is the first slide that I started with. All that debris in the brain. Inflammation is really easy to understand, actually. It's the body's way of getting rid of a splinter. That's the way I look at it. An irritant. If you have an irritant, the sympathetic nervous system is Johnny on the spot, and it sends all its army to get rid of that irritant. And you got plenty of irritants. You got dead cells, you got blood, you got reactive oxygen species, you got heck of things. Insult removed. The end. Inflammation resolves. It's not chronic inflammation. Who's your army? Your army is the immune system. You met one of them, microglia. See, there they are eating up amyloid beta. Don't get too stressed over the slide. I just want to show you that what happens in the brain is not just the microglia that happen to live there show up. It's what my mother used to call a mob scene. I mean, inflammatory cells come from everywhere in the body to help the brain out. And the one place that I want to just kind of let you know is one of the places that they come from is the skull. Neutrophils, which are these little annoying, really potent immune cells that blow things up and use chemical weapons to get rid of the debris, show up really quickly. And they can't figure out why, because they don't live in the brain. The brain wouldn't let them live there. They're too dangerous. Where do they come from? Turns out they come from the skull. They come from the marrow cavity. It goes from the marrow through those channels. And this is the movie that I had playing earlier. They now have this in 3D. There are channels from the marrow to the inside of the skull, and from the skull into the sinuses, and right into the meninges, into the blood vessels of the meninges. And this is a 3D model of, which I put up because it's really cool. There are channels from the marrow to the meninges, from the meninges to the brain. And so the neutrophils get to the brain really quickly. Also, bleeding gets to the brain really quickly. If you have bleeding between, the scalp and the skull, if you have bleeding somewhere in the meninges, it gets to the brain through the same passageways. Okay. With all that army in there, why doesn't that circle get smaller? Right? That circle is the damage, right? And as concussion goes on, it should be getting smaller. All those immune cells are cleaning up that debris, but it gets bigger. And the reason is, of course, because inflammation and that army is like an out-of-control army a little bit. It does a good job, let's face it, but it causes bystander damage, just like any army does. And then the bystanders, the brain gets injured, it sends out SOS. It sends out an SOS call. And in response, the immune system shows up. Well, if you damage the bystanders send out an SOS. And then more immune cells show up. And it goes on forever until you stop it, until it stops. This is the pharmaceutical approach. Their idea is, let's look at inflammation. First they call for help. That's the DAMPs. That's a SOS call. First they call for, maybe we shouldn't let them call for it. Maybe we should take down the transmission towers. Maybe we should take the radios from the immune cells so they can't hear it. Maybe we should let the air out of the tires of the army so they can't get there. That's kind of their idea. And to me, that's like saying, there's so much crime in my neighborhood, and everyone is calling 911. What can we do? And the answer is, stop calling 911. Which, I mean, and it's about as successful. If you try to stop the inflammatory process, you just cause more harm. So, and just for those of you who practice in a somewhat more traditional way, you should know that many anti-inflammatory drugs are what they call resolution toxic, because they know that inflammation now not only has a certain way to start, it has a certain way to resolve. It has a very specific resolution pathway, and a lot of anti-inflammatory drugs cut that resolution pathway off. So it's not to say that you should never use them, it's just you should know that this is a consideration. Okay, so you know how to clean out, you know how to stop inflammation. You sweep that debris out with cerebrospinal fluid, with fluid flow. Who needs a refresher on the lymphatic system? Everybody, you need okay. So about 4 years ago, they found the lymphatic system. So you got your subarachnoid space, and then you have your peel covering of the brain, and it folds in, and it creates tunnels called the Virchow-Robin spaces. And the arteries go down that tunnel. And there's enough room around the arteries for cerebrospinal fluid to flow. And it flows in, and it goes into the brain, and it sweeps away the debris. So you have cerebrospinal fluid flushing into the deepest part of the brain, and then it goes into the parenchyma itself, and it sweeps that debris out. Amyloid beta, all of those damaging proteins, it sweeps them into the venous system on the other side. It goes back into the subarachnoid space. Okay, so that's like, everyone was so excited about that. All the cranial osteopaths were like, we told you. And that's true. So here's the thing. It's a fluid system. It needs a pump. So when you're working with cerebrospinal fluid, think about the pumps, the thing that's pumping that. There are 3 pumps. One I'm not going to talk about, even though it's the most intriguing, which is they keep finding this inherent motion in the brain, and they don't know what it is. And it's not connected to the heartbeat, and it's not connected to respiration, but it's there. And they measured it in its very low frequency waves. They don't know what it is. Hint, talk to a cranial osteopath. I'm going to talk about the other 2. The first pump is inspiration. They found that they studied forced inspiration, which is 2.5 seconds inspire, 2.5 exhale. And what they found is that every time you take a breath, cerebrospinal fluid flushes up the spinal cord, past the 4th ventricle, into the aqueduct. And what's amazing, and you exhale, and it goes the other way, and they're realizing it's a pulse. They're realizing 2 things. Number 1, it doesn't just go one direction through the 4th ventricle, it goes 2 ways. And the second thing is they're realizing that cerebrospinal fluid is pulsatile. It's a tide. It's not necessarily just a flow. I just thought you guys might be interested in this. They did this in an MRI, and they compared thoracic breathing and abdominal and diaphragmatic breathing and the motion of the diaphragm. It makes the biggest difference. It makes some difference in terms of pumping it through the skull, but it makes the biggest difference in the low back and the thorax, which I thought was really cool. Okay. Why is it that what you do is so successful? One of the reasons is, I believe, you work with the breath and the diaphragm. You're pumping cerebrospinal fluid. Don't forget, it has to get out of the brain, because as you inhale and cerebrospinal fluid goes in, venous blood goes out. As the venous blood goes out, it creates enough room in the brain for cerebrospinal fluid to pulse in. So those 2 flows are very intimately connected, which means that the blood has to get out of the brain. Everybody forgets that. They had those young kids in that MRI but they're all healthy kids. You know, after a traumatic brain injury, you can have very restricted flow of venous blood out of the brain, and that's going to clog up your lymphatic system. This was a study that they looked at people who had recovered for almost a year from one minor concussion, and they did a study of their internal jugular veins, which is the main route out of your brain. And on the right, you can barely see them. They are so congested. Is that because of the neck? Is that because the jugular foramen is pinched? They didn't go that far. But fortunately, since osteopaths treat the whole body, you know, just be aware that it's not enough to pump cerebrospinal fluid. You have to get the venous blood out of the brain too. Okay, so the next thing that pumps cerebrospinal fluid is arterial flow. And they did this study with kids who slept in an MRI. Who else could sleep in an MRI except a kid? But they had volunteers sleeping in an MRI. And what I want to show you is that blue flash. As venous blood is leaving the brain, cerebrospinal fluid is flowing up. That blue flash is in the fourth ventricle. And that is the flow of cerebrospinal fluid. And they say that when you are asleep, it's like a tsunami coming into your brain. So the rule of the artery is supreme. So it's, you know, and this is, it drives lymphatic flow when you're sleeping. Someone asked me about this, and the reason is norepinephrine goes to sleep. In non-REM, it's got to be non-REM sleep, when your brain is totally quiet. And the locus coeruleus, which produces all the norepinephrine, goes and takes a nap also. The brain literally shrinks. And also, it doesn't need as much perfusion. So blood circulation drops, cerebrospinal fluid flows in like a tsunami. But it's when you're sleeping. So one of the reasons you have to sleep after a concussion is that's the way you clear out your brain. And someone asked me a question about anesthesia. It's the same thing. If you give somebody anesthesia that quiets the locus coeruleus, you know, that quiets norepinephrine, you will have very robust lymphatic flow. If you give somebody, because they anesthetize these mice, and they're like, some people got one result and other people got another result, and they're like, you gave them the wrong anesthesia. You gave them an anesthetic that didn't quiet the sympathetic overdrive. So if you know, the norepinephrine runs this system in a way. Okay, so you got it pumping. It's awesome. How do you get it out of the brain? You still got to get it out of the brain. You're pumping it like mad. All right, 4 exit routes. First route you know about, spinal nerves. It goes through the spine, of course. The second thing is it goes through the arachnoid granules, right? The arachnoid granules hang down into the subarachnoid space. It turns out that's really not a very productive route. They don't think anymore. This is all up in the air. No one knows anymore. That spinning brain is not a picture of the dural sinuses. It's a picture of the meningeal lymphatics. So about 3 years ago, they discovered a system of actual lymphatic vessels in the dura. And they parallel the sinuses and some of the major arteries. And, everyone said there are no lymphatics in the brain. Well, guess what? There are. And we don't know a whole lot about them yet. But they seem to be really critical to lymphatic drainage. If you clog up the meningeal lymphatics, the whole lymphatic system shuts down. It causes amyloid to back up, you get learning deficits, and it actually changed expression in the hippocampus to all of these neurodegenerative diseases, which is kind of intriguing. So when you're pumping the lymphatics, when you're pumping cerebrospinal fluid in the brain, you're also pumping the meningeal lymphatics, and your techniques for pumping the sinuses also pumps the meningeal lymphatics. And the last one. The one that I really want you guys to know about is the cranial nerves, especially the olfactory nerves. This is one of the major routes that heals or injures the brain. If you want to give a mouse Alzheimer's disease, you block up the cribriform plate and you don't let cerebrospinal fluid drain through the cribriform plate. So there's your olfactory tract. You got your olfactory bulb right there, and you got your nerves going through the cerebrospinal fluid right through the cribriform plate. It kind of looks like that. And around those nerve bundles, cerebrospinal fluid flows. Also within the nerve itself, it's flowing. Alzheimer's patients have significantly reduced flow through this passageway. And they have many fewer turbinates. What's the first sign of Alzheimer's? It's the loss of the sense of smell. Once those nerves die, the flow through the cribriform plate is vastly reduced. The olfactory bulb is deeply tied to memory. It's deeply tied to fear center, the amygdala. I mean, in other mammals, the sense of smell is much more important. You know, it tells you when to be afraid. It tells you when to remember. You know, our sense of smell is not nearly as acute, and our structures have shrunk quite a bit, but we still carry that heritage of having our olfactories hooked to our memory and olfactories hooked to our fear centers. The hippocampus, the fear center, the amygdala, preferentially drain their debris forward through the olfactory plate. So if you tie up the cribriform plate, you can cause a mouse to get neurological problems. And if you just ablate the nerves and you end that passageway through the nerves, it greatly reduces CSF flow and it causes neurological diseases. So there's it. The brain takes a lot, the last thing I'm going to say is the brain takes a lot of energy to protect this passageway. They literally found another set of lymphatic vessels in the brain. They go right through the cribriform plate into the flow of cerebrospinal fluid. And if you start creating injury to the hippocampus artificially, it starts to grow. It adds more lymphatic vessels. So the brain really protects this real estate. And the other thing is, it protects this real estate because the largest stem cell niche in the brain connects directly, it sends its neurons to the olfactory bulb. That is really precious real estate. There you got your two stem cell. I was going to do more on stem cells, but if you ever want to get into an argument with a researcher, just say stem cells, and everyone argues with you. There's too much money involved. You know, it's a very dicey area. But you got two areas that feed into the olfactory bulb. And what triggers stem cells to know, to wake up, to go to the olfactory bulb when it's injured? Cerebrospinal fluid. The flow of cerebrospinal fluid literally opens up channels in the stem cell niche and instructs them to get going. And what is it that controls that? It's not on this slide. The choroid process. The choroid process is like the Jedi of the brain. It's sniffing around and it senses disturbances in the force. And when it picks up injury, it instructs the stem cells to start reproducing. So when you're working with cerebrospinal fluid flow in the ventricles, you are also working with regenerating the brain. Stem cells in that niche have their hand in the flow of cerebrospinal fluid. They literally have one appendage in that flow. So they know when it is to get going. Now, the last question is, how do they get there? The first way they get there, when you were young, there was a little migratory stream that went from your ventricle right to your olfactory bulb and gave you lots of new neurons. That supposedly dries up when you get older. But I found this research paper from about 12 years ago. Somebody found an extension of the lateral ventricle that goes right into the olfactory bulb. So they don't have to worry about how to get there. And the second way is they form a chain. What do? You take an Uber? How do you get from the subventricular zone? How do you form a chain? And it's like the whole brain lights up, and they start basically lighting up the way, and those stem cells climb hand over hand to get to regenerate that area of the brain. The extracellular matrix, which is something that's becoming very much more popular, provides a scaffold for it. Why is it that what you do is so successful? You're helping the brain regenerate itself with your work through cerebrospinal fluid. It really is the great river of life that has to be tapped, because without it, the brain will perish. Okay, so I'm almost done. Last section, restore movement and alignment. Remember your city? Okay, so you fixed it. You calmed down the autonomic nervous system, you rebuilt the roads. Your house is still crooked. That's good. You got the sewers working. Your house is still crooked. You have to fix the structure. You gotta pump it up. So this is, there's all these details and everything, but this is what it's like. This is why I say you gotta fix the structure. Let's say you wanted to fix your closet. You wanted to organize your closet, and you decided to hire Arnold Schwarzenegger.
Let's say you're procrastinating cleaning your closet. Well, just blow it up.
So what do you think would happen to your closet after all the debris cleared? Do you think it would be very well organized? Or do you think it would be just a mess? What did you just do to your brain? You just blew up your brain. Of course it's not going to be in the same place. Why does inflammation persist for 47 years? I was obsessed with this research paper. Why did that happen? They looked, and they said the inflammation was along a very specific white matter tract. And they said, perhaps it's along, the passageway that was initially injured. I'm like, that's what happened. Not only was it injured, it's still being injured because it's stretched, because the structures moved around and they stretched, they ended up in the wrong place, and so the structures are being stretched. And axons hate to be stretched. And so slowly, when the brain is not a spring. When you injure it, it doesn't just spring back. It's twisted, it's stretched, it's deformed. And if you don't fix it, very slowly, it will degenerate. In the first 15 milliseconds, I'm just going to give you a quick situation of why I think that's true. First 15 milliseconds, after you get hit, your skull rings like a bell. It vibrates all along its length. It creates pressure gradients that pull and stretch the brain itself. It expands opposite the blow. It flexes at the sutures. What's under the skull? Of course, the dura is attached to the skull. And as Chris Brown and other people who wrote this this terrific paper where they had 2 severe brain injury patients who walked out of the hospital fine, everything is connected. You stretch the dura, you're stretching everything below it. 49% of people who have concussions have bleeding in the dura. And we saw, because of the channels, the bleeding makes its way to the parenchyma of the brain itself. And bleeding is very damaging to neural tissue. Okay. What else rings? Not only does your skull vibrate, your brain vibrates. They measured it between 20 hertz and 35, just for instance. And different areas of your brain ring and vibrate at different rates. In this situation where you had loss of consciousness, you can see the huge difference between the corpus callosum and everything underneath it. And so when you have brain tissue vibrating at different rates, it's starting to pull itself apart. What's under the fox, the dura, is the fox. Now, we suspected this for a long time, that injury to the fox damaged the corpus callosum. But now we have the study that proves it. Okay, this is what they think happens when you get hit from the side and when you get hit with a rotation, is that it connects to the corpus callosum under it and it strains it. We don't have. So this is a guy from Stanford. He was an engineer and a football player. He invented a mouth guard that measures the motion of the skull and what they found in concussed football players.
So this is our laboratory, and I want to show you the first concussion that we measured with this device. One of the things that I should point out is the device has this gyroscope in it, and that allows you to measure the rotation of the head. Most experts think that that's the critical factor that might start to tell us what is happening in concussion. So please watch this video.
Burgers bring extra people late, but Luck has time. Oh, Lucy is crushed. I hope that he's all right. Top of your screen, you'll see him come on just this little post route, get separation, safety. And here it comes at you in real speed. You'll hear this. The hit delivered by Case.
Sorry, 3 times was probably a little excessive there, but you get the idea. So when you look at just the film here, pretty much the only thing you can see is he got hit really hard and he was hurt. But when we extract the data out of the mouth guard that he was wearing, we can see much more detail, much richer information. And one of the things that we noticed here is that he was struck in the lower left side of his face mask. And so that did something first that was a little counterintuitive. His head did not move to the right. In fact, it rotated first to the left. Then as the neck began to compress, the force of the blow caused it to whip back to the right. So this left-right motion was sort of a whiplash type phenomena, and then we think that is probably what led to the brain injury. Now, this device is only limited in such that it can measure the skull motion, but what we really want to know is what's happening inside of the brain. So we collaborate with Svein Kleiven's group in Sweden. They've developed a finite element model of the brain. And so this is a simulation using the data from our mouth guard from the injury I just showed you. And what you see is the brain. This is a cross-section right in the front of the brain twisting and contorting, as I mentioned. So you can see this doesn't look a lot like the CDC video. Now, the colors that you're looking at are how much the brain tissue is being stretched. And so the red is 50%. That means the brain has been stretched to 50% its original length, the tissue in that particular area.
That is the motion of the fox when you get hit in a coronal this way. The fox can literally move 7 to 8 millimeters. And so it's pushing everything on the side of it, which means all of the white matter tracts are stretching. Then it rebounds and the brain trampolines off of it and goes smacking the other way. And they find that when you get hit in a coronal way, it puts tremendous strain on the middle of the corpus callosum, and when you get hit in an axial rotation, in a horizontal rotation, it strains the 2 ends of the corpus callosum. Okay, so the last thing I'm going to talk about is a pressure wave through the vasculature itself. We had a pressure wave through the skull, through the parenchyma. You know, you got 400 miles of blood vessels. And a shock wave goes through those 400 miles and the ventricles. They think that cavitation may be one of the reasons there is so much damage in a concussion. And cavitation, when you put tremendous sudden pressure on a certain type of liquid, bubbles form, and then as the bubbles explode, they shatter everything near it. This is apparently a party trick that people do. Bubbles form, bubbles collapse, and the pressure of them exploding can literally blow up a piece of glass. And you can do it in a test tube. So they think that might be happening in your blood vessels, in the bigger ones. In the smaller ones, the ones that penetrate into your parenchyma, I mean, that is hypothetical. They don't know yet. But there is a study that came out about a month ago that showed that in the arterioles, in the smallest vessels in the middle of your parenchyma, that shock wave creates pressure differentials between arterioles that damages the brain in very specific patterns. So there is a shock wave that goes all the way through the vasculature. So you want to know why I say the brain has been stretched? Because of all of those things. They hate to be stretched. And white matter regions are the most stretched. These are the most stretched. They studied football players before and after a season and concussions, and they all had injuries no matter where they were hit in these white matter tracts. The uncinate, part of the Fight Club, the white matter tracts that run parallel, and parts of the corpus callosum. And they heal back to front. And front is the last place that they heal. The connection to the cortex is the last place they heal because that's the last place that's myelinated. Okay. You know, I thought, what is this theory that, that we've come up with? That if you stretch brain tissue and it doesn't quite go back and it has a little stretch in it, that you've basically wrung a little bit of resilience out of the brain so that even minor dings that wouldn't ordinarily bother you are still injuring it because they stretch it and they stretch it and they stretch it. And I thought, who would ever do that experiment? And then they did it. They took brain tissue and they stretched it they kept it stretched and then they stretched it just a little bit and a little bit. And they found out that the axons started to collapse over a period of time. They never get the opportunity to heal, is the basic. And it eventually, I mean, you're talking about a timeline of years. So does stretch injury stay in the brain? In this study from a bunch of radiologists, they looked at some concussion patients who weren't getting better, and they found that the tent was flat. So I appeal to your knowledge of anatomy to think about all of the structures in the brain that are now out of place because the tent is out of place. All the connections, all the ventricles, all the dural sinuses. So yes, at least in some instances, we have evidence that there is structural change that can provoke stretch. Does stretch damage the brain? This study came out about 2 months ago. If you lose volume in your brain, which is pretty common after even a mild concussion, the loss of volume stretches the remaining tissue. It puts strain into the von Mises, they call it stretch, into the remaining tissue. And over a period of years, it starts to cascade. That stretch injury takes the resilience out of the brain. It can't recover as well. And so gradually, small little movements start to wear it out, and slowly it dies until it all of a sudden explodes and you get, that kind of brain at the end. It's like they say concussion is an acceleration of aging. So you got to put the brain back where it belongs. Displaced brains are stretched or disintegrating neurons. Okay. We can't replace our brains. This is what coaches would like to do. They would just like to take another brain out and put it in their player so that their players could go back. But we can't do that. But we have the next best thing, which is you. Because you calm the autonomics, you work the fluid flow, you help stem cells regenerate, and you take the strain out of the tissues so that the brain can heal. Bottom line, trust your hands. You can feel, even untutored touch can feel the difference in surface of a single layer of molecules. So, as a layperson, I say, imagine what your trained touch can do. So, I hope that's helpful. I hope that you got something of value. And if you have any thoughts or questions, or if you have a favorite part of the brain you want me to talk about next time, let me know. Okay, thank you.